Welcome to the deep dive. Today, we're tackling a really huge topic, one that touches almost everyone: contraception and family planning. And we're not just scratching the surface here.
No, definitely not.
We've gone through a lot of complex medical sources. Our mission is a proper deep dive, aiming for that mastery level understanding. We want to get into the mechanisms, the real world failure rates, the reasons why certain methods are used, and all the modern ways they're delivered.
That's right. And it's a dense field when you dig into the source material. We're talking everything from, rhythm methods based on awareness all the way to sophisticated hormonal implants and surgical options.
And understanding why someone picks one method over another is key, right? Plus how we actually measure if it works reliably, that Pearl Index thing.
Exactly. The Pearl Index is crucial for comparison. But before we even get to the methods themselves, it's important to set the stage. Why is limiting family size such a big deal today?
Yeah, what are the fundamental drivers here? It's not just about personal preference, is it?
No, not at all. On a personal level, you see clear economic pressures. I mean, the cost of living keeps going up. People want better education for their kids, a higher standard of living.
Hmm.
That often means planning for fewer children.
Makes sense. But there's a huge health angle, too.
Absolutely.
Yeah.
From a medical standpoint, birth control is fundamentally a health measure. It's about avoiding the very real risks that come with repeated, maybe unwanted pregnancies.
What kind of risks are we talking about?
Well, for starters, the evidence is pretty clear that spacing births about 3 years apart is much better for the mother's health recovery and for the child's development, too.
Okay.
And think about age extremes. A pregnancy in someone under, say, 18 or 20. She often hasn't finished growing physically. That's a high-risk situation for both her and the baby, often leads to low birth weight, other complications.
And at the other end, women who've had many children already.
Exactly. Multiparous women, especially in lower-income situations, often face chronic health problems. They might be malnourished, anemic, and repeated births increase the risk of serious long-term issues like uterine prolapse, chronic infections like cervicitis, even potentially cervical cancer.
So contraception in those cases is genuinely a health intervention.
It really is. Limiting pregnancies becomes incredibly important for her long-term health and well-being. It can be life-saving, frankly.
Okay, so when we talk about managing fertility, there are basically three distinct routes people can take, depending on the timing. Let's unpack this.
Right. 3 main approaches. First, you have contraceptives. Their whole purpose is to prevent fertilization from happening in the first place. Sperm meets egg. They try to stop that.
Got it. Prevent the start. What's next?
Second is emergency contraception. This comes into play after unprotected intercourse has already happened. Its goal is usually to prevent the fertilized egg from implanting in the uterus.
So a backup plan.
Kind of, yeah. And the third approach, if the first two haven't worked or weren't used, is medical termination of pregnancy, or MTP. That's abortion.
And I think the core message coming through all the sources is pretty clear on this.
Absolutely. The best approach, by far, is using effective contraception consistently. It minimizes the need for emergency measures or termination, which obviously carry more physical or psychological weight.
Okay, that sets the stage really well. Let's dive into the methods themselves, starting with how someone even chooses one.
Right. Choosing a method. It's rarely straightforward. It's deeply personal. You got to consider the couple's age, whether they have kids already, that's parity. Then there's cost, availability, critically the side effects, and any medical reasons why a method might not be suitable, the contraindications.
And reliability, of course. How well does it actually work?
Exactly. That failure rate has to be balanced against everything else. And, counseling is absolutely essential here.
Because it's not a decision made once and forever.
Not at all. The
Yeah.
sources really emphasize this. People often need to change methods over time. Their health changes, their relationship status might change, their family goals evolve. What works for a young woman might be totally different from what's best for someone in her late 30s who's finished having children.
That makes sense. Good counseling is key. Now, you mentioned reliability. We need that common metric. Tell us about the Pearl Index again.
Okay, the Pearl Index. It's the standard measure for contraceptive failure. Basically, it tells you the pregnancy rate per 100 woman years.
So what does that mean in practice?
It means if you take 100 women using a specific method consistently for 1 year, the Pearl Index is the number of those women who would likely become pregnant during that year. It lets us compare, say, the pill versus an IUD on a level playing field.
Got it. So a lower Pearl Index means a more effective method.
Precisely. Now, if we were to imagine the perfect contraceptive, what would that look like according to the research?
Yeah, what's the sort of holy grail here?
Well, the ideal would be super effective, obviously, long-acting, so you don't have to think about it constantly, extremely safe, and a really key one today, coital independent.
Meaning it doesn't interfere with sex itself?
Exactly. No stopping to put something on or remembering to take something right before. Beyond that, it needs to be easily available, affordable, completely reversible if you change your mind, and have virtually no side effects. That's the dream target.
A tall order. Okay, let's start with the methods that tick the no cost, no devices boxes, the natural methods, fertility awareness and abstinence.
Right. The basic idea here is figuring out the woman's fertile window, the days around ovulation when pregnancy is possible, and just avoiding intercourse during that time.
The classic example is the calendar method or rhythm method,
Uh-huh.
but it's known for not being very reliable.
That's putting it mildly. Its efficacy is quite low. So the theory is, in a perfect 28-day cycle, ovulation is around day 14. But sperm can survive for a day or so. The egg may be 12-24 hours. So the risky period is roughly days 11 to 17.
But cycles are rarely perfect, are they?
Almost never. That's the core problem. There's a calculation, the Nasogino method, that tries to account for cycle variability.
How does that work? Sounds complicated.
It involves tracking cycles over time. You take the shortest cycle length and subtract 18 days. That's the start of the estimated fertile window. Then you take the longest cycle length and subtract 10 days. That's the end.
Okay, give me an example.
Sure. Say a woman's cycles range from 28 to 35 days. Shortest is 28, minus 18 is 10. Longest is 35, minus 10 is 25. So her calculated fertile window is day 10 through day 25.
Wow, that's more than half the month requiring abstinence.
Exactly. And even with that, the failure rate is incredibly high, around 25 pregnancies per 100 woman years. Irregular cycles just throw the math off too easily. Plus, it requires meticulous tracking that most people, frankly, don't sustain long term.
Now, I saw mention of a tech solution here, the Persona microcomputer. This sounds interesting, like trying to fix the unreliability. Why isn't this everywhere?
Persona is quite clever, actually. It's like a mini lab for your bathroom. It measures hormone levels in morning urine using a test stick, specifically estrone 3-glycuronide, and crucially, luteinizing hormone, LH.
And LH is the trigger for ovulation, right?
Precisely. The big surge in LH happens just before the egg is released. So by tracking that surge, Persona can pinpoint the fertile window much more accurately than just counting days.
It gives a traffic light signal.
That's right. Green light means it's considered safe. Red light means the LH surge is happening or about to happen. That's the high fertility warning. This tech approach does drop the failure rate dramatically, down to maybe 6 per 100 woman years.
So why isn't it more common?
Mostly cost and convenience, I think. The device itself isn't cheap, and you need those disposable test sticks every day. Compared to, say, condoms or pills, it's just less accessible for many people.
Okay. Let's move to another awareness method, this one based on bodily signs, the mucus method or Billings method.
This one relies purely on the woman observing changes in her cervical mucus throughout the cycle. These changes are driven by hormones. Estrogen makes the mucus thin, clear, stretchy, often described like raw egg white. This builds up to a peak day.
And after ovulation,
Progesterone takes over, making the mucus thick, cloudy, sticky, and eventually it dries up. The rule for the Billings method is abstinence from the very first day any mucus appears until the 4th day after that peak day of stretchy mucus.
requires a lot of self-awareness and diligence.
It really does. Similar diligence is needed for the basal body temperature, or BBT, method.
How does that work? Tracking temperature.
Yeah, tracking the body's lowest resting temperature, the BBT, first thing every morning. After ovulation, the release of progesterone causes a slight but sustained rise in temperature. This is called the thermogenic effect.
So the temperature chart shows 2 phases lower before ovulation, higher after.
Exactly, a biphasic chart. The key thing here is the temperature rise tells you ovulation has already happened. So it confirms the fertile window is closing or closed. But it's very easily thrown off by things like illness, stress, even a bad night's sleep. It's considered pretty cumbersome and isn't widely used as a primary method now.
Okay, on to one that's very common despite its flaws. Coitus interruptus, the withdrawal method. That 25% failure rate is huge, same as the calendar method.
It is, yet it's practiced globally because, well, it's free and requires no devices. But the sources highlight a really critical point about why it fails so often, and it's not always what people think.
What's the surprising part here? I always assumed it was just about, pulling out too late.
That can happen, of course.
Yeah.
But the main biological reason for failure, even with seemingly perfect timing, is the presence of active sperm in the pre-ejaculatory fluid.
The fluid released before actual ejaculation.
Exactly. That clear fluid from the prostate gland often contains enough live sperm to cause pregnancy. So, even if withdrawal happens before the main ejaculation, fertilization can still occur. Plus, there's the psychological side. It can cause significant anxiety for the man and potentially impact satisfaction for both partners.
Right. Let's round out the natural methods with one specific to postpartum, LAM, the lactational amenorrhea method.
LAM is quite effective, but only under specific conditions during the first 6 months after childbirth. The mechanism is fascinating. Frequent exclusive breastfeeding, especially including night feeds, keeps prolactin levels really high.
And prolactin stops ovulation?
Pretty much.
Yeah.
High prolactin suppresses the LH surge needed for ovulation. So as long as the mother's breastfeeding frequently and hasn't had her period return, she's amenorrhoic, the protection is remarkably good. The failure rate can be as low as 0.5% to 1.5% during those first 6 months under those strict conditions. But, and this is a big pig, but the protection stops working effectively right around the 6-month mark, or as soon as periods return or breastfeeding frequency drops. Ovulation can return quite suddenly.
So summing up all these natural methods, calendar, mucus, temperature, withdrawal, LAM, they share some pros and cons.
Definitely. The advantages are clear. No cost, no hormonal or physical side effects, no impact on future fertility. LAM is great for breastfeeding moms initially, but the big shared disadvantages are significant. Generally high failure rates, except for perfect use LAM, requiring immense motivation and discipline, and crucially, zero protection against STDs or HIV.
That lack of STD protection is a major drawback for the whole category.
It's fundamental, yes.
Okay, let's move on to methods that provide a physical or chemical block. The barrier methods, condoms first, male and female.
Right, the male condom is the most familiar, usually a thin latex sheath, single use. Really important point, the source of stress is lubricant choice. Always use water-based lubricants.
Why is that so critical?
Because oil-based lubricants, think petroleum jelly, baby oil, some lotions can actually damage latex, causing tiny holes or weakening it, leading to breaks. If someone has a latex allergy, there are polyurethane condoms, but they tend to cost more, and some find they slip or break more easily.
Condoms offer way more than just pregnancy prevention, though. That's their huge public health advantage.
Absolutely. They're cheap, easy to get hold of, work immediately, and importantly, they involve the male partner. But the biggest benefits are health-related. They are highly effective at preventing the transmission of HIV and other STDs like chlamydia, gonorrhea, syphilis.
And they even reduce the risk of certain cancers.
Yes, studies show they decrease the incidence of cervical cancer in women. This is thought to be by blocking the transmission of viruses like HPV, which are known to cause cervical cancer.
So with all those benefits, why is the typical use failure rate still around 10 to 14 per 100 woman years? That seems quite high.
It does, and it really highlights the difference between perfect use and real-world use. The failures are almost always down to human factors.
Yeah.
Not using one every time, putting it on incorrectly, breakage, slippage. It's coitus dependent, meaning you have to stop and use it right then, which can lead to inconsistent use.
And there's that specific use case after a vasectomy.
Right. Super important reminder. After a vasectomy, a man isn't immediately sterile. He needs to use condoms for about the first 12 ejaculations, or roughly 3 months, because there's still live sperm stored in the tubes beyond where the cut was made. Semen analysis confirmation is needed.
Okay. Now, what about spermicides used on their own, the chemical barrier?
Spermicides contain chemicals like nonoxynol 9 or octoxinol designed to kill sperm. They come as foams, creams, jellies, suppositories. Used alone, though, their effectiveness is very poor.
How poor?
We're talking a failure rate of maybe 30 per 100 woman years. Very high. And they only work for about an hour or two after insertion.
Now, here's a really critical detail, especially thinking about HIV risk. Chronic use can actually backfire.
This is a crucial point that's emerged. Frequent use of spermicides like nonoxynol 9 can actually irritate the vaginal lining, causing tiny abrasions or even ulcerations.
Which paradoxically makes transmission easier.
Exactly. That damaged tissue can provide an easier entry point for viruses like HIV. So traditional spermicides are generally not recommended for couples where HIV is a concern, especially for the uninfected partner trying to prevent acquisition.
But research is looking for safer alternative.
Yes. There's work on developing non-irritating microbicides, like tenofovir cream, which aim to block viral entry without damaging the tissue. And in India, there are trials on preneem, derived from the neem tree, as a potentially safer spermicidal agent. The focus is shifting away from just killing sperm to safer, potentially antiviral, agents.
Okay, let's talk about the female-controlled barriers that block the cervix, diaphragms and cervical caps. These seem to require more user effort.
They definitely do. A diaphragm or cap must be used with a spermicide. It needs to be inserted before intercourse and, critically, left in place for at least 8 hours after intercourse to ensure all sperm are killed.
And fitting is key.
Absolutely. The woman needs to be properly fitted by a healthcare provider initially and taught how to insert and remove it correctly. And the fit needs to be rechecked, maybe even requiring a different size after significant weight changes, childbirth, usually 6 to 8 weeks postpartum, or even pelvic surgery.
Describe the diaphragm, the Dutch cap.
It's a dome-shaped rubber cup with a flexible spring rim. Sizes vary, but common ones are 65–80 millimeters across. It sits in the vagina, covering the cervix. When fitted and used correctly with spermicide, the failure rate is fairly low, around 4 to 6 per 100 woman years. But failures are almost always due to poor fit or incorrect use.
Are there situations where it shouldn't be used?
Yes, contraindications include significant uterine prolapse, it won't stay in place, recurrent UTIs, it can sometimes increase risk, or latex allergy. And a very important warning. Leaving it in for too long, say, over 24 hours, carries a small risk of toxic shock syndrome, TSS.
What about the cervical cap? How is it different?
The cervical cap is smaller, more thimble-shaped. It fits snugly right over the cervix itself rather than spanning the upper vagina. It might be a better option for women with mild prolapse where a diaphragm might slip.
Now, the female condom FemShield or Femidom, this seems to offer protection similar to the male condom, but is woman-controlled.
Yes, the female condom is a really important option. It's a pouch, usually made of polyurethane, about 15–17 centimeters long, with flexible rings at each end. One ring helps with insertion and sits inside near the cervix. The other stays outside, covering the external genitalia.
What are its main advantages?
It's strong, potentially stronger than latex male condoms. It provides excellent protection against STDs and HIV, possibly even better than male condoms because it covers more external skin. It's woman-controlled and it's coital independent. It can be inserted hours beforehand. Plus, it can be used right after childbirth.
Any downsides?
The main ones are costing-adential. They're significantly more expensive than male condoms, maybe $2–3 each. And the failure rate is a bit higher and wider ranging, typically cited as 5 to 15 per 100 woman years, likely reflecting a learning curve for proper use.
Lastly, in this category, the vaginal sponge, like the Today sponge.
Right. The sponge is a disposable, single-use device made of polyurethane, about 2 inches across. It comes preloaded with spermicide, naloxone 9.
How does it work?
It has a kind of triple action.
Yeah.
It's a physical barrier over the cervix, it absorbs semen, and it continuously releases spermicide. It's designed to be effective for up to 24 hours, regardless of how many times intercourse occurs during that period. But it must be left in for at least 6 hours after the last act.
Disadvantages.
Similar to others in this group. Cost. It's still coitus-dependent in the sense you need to insert it beforehand, and again, that risk of TSS if left in too long.
Okay, that covers barriers. Now we move into a totally different category. Intrauterine contraceptive devices, or IUCDs. These are long-term, reversible, and highly effective.
Exactly. IUCDs represent a major shift towards set-it-and-forget-it's contraception, though regular checks are still needed. The basic structure is usually a small, flexible plastic frame, often T-shaped. They're made with polyethylene mixed with barium sulfate.
Why the barium sulfate?
That makes them radiopaque, so they show up on X-rays or ultrasound. This is crucial for checking placement or finding it if the threads aren't visible. And they all have signed nylon threads attached which hang down through the cervix into the vagina. These allow the woman or provider to check it's still in place, and they're used for removal.
We can group IUCDs into types, right? Inert, copper, hormonal.
Correct. The first generation were inert, meaning just the plastic frame itself, like the lips loop. These aren't widely used anymore in most places, though still common in China apparently, and were part of India's early family planning program.
Today, the medicated ones are standard. Let's talk copper IUCDs.
These are the workhorses. They have fine copper wire wrapped around the plastic frame or copper sleeves on the arms. Examples are the copper T200, copper T380A, multi-load devices. The number refers to the surface area of copper in square millimeters.
And the amount of copper dictates how long they last?
Generally, yes, and the specific design. The copper T380A, like Paragard in the U.S., is approved for 10 years of use. It releases about 50 micrograms of copper per day. Others might be 3 or 5 years. Some, like the Ovid T, add a silver core to the copper wire to prevent fragmentation and ensure consistent release over 5 years.
Okay, then we have the hormone-releasing IUCDs.
Right. There are two main types here. Progestogen was an earlier one. It's T-shaped and releases progesterone about 65 micrograms daily. Its main advantage over copper was reducing menstrual bleeding and cramps, which can sometimes be worse with copper IUCDs. But it needed yearly replacement.
Which leads us to Mirena, the current big player in hormonal IUCDs.
Mirena is a game changer for many. It contains 52 milligrams of a progestogen called levonorgestrel, LNG. It releases a much lower dose, about 20 micrograms per day, and is effective for 5 years, with newer versions potentially lasting longer.
And its effectiveness?
It's incredibly effective. The pregnancy rate is extremely low, around 0 to 0.3 per 100 woman years. That's comparable to female sterilization, but it's completely reversible. And because the hormone effect is mostly localized within the uterus, it's considered safe for breastfeeding mothers.
There are also frameless IUCDs.
Yes, like GYNAECOLOGY. These consist of copper beads on a thread that's anchored into the muscle at the top of the uterus, the fundus. The idea is that being frameless allows it to conform better to the uterine cavity, potentially reducing side effects like pain or expulsion, sometimes seen with framed devices.
Now, the mechanism of action for IUCDs, this is where it gets really interesting, isn't it? It's not just blocking things physically.
Not at all. It's much more complex and involves triggering a local inflammatory response within the uterus. Basically, the IUCD acts as a foreign body.
So what does that foreign body do?
Several things happen simultaneously. First, it makes it physically harder for sperm to swim up towards the fallopian tubes. Second, the presence of the device causes the uterine lining to release prostaglandins.
And prostaglandins affect muscle contraction.
Yes, they increase uterine contractions and also speed up the movement within the fallopian tubes, tubal peristalsis. This means if fertilization does occur in the tube, the egg is rushed into the uterus way too quickly before the lining is ready for implantation. It arrives too early.
And the body's immune system gets involved too.
Absolutely. There's a significant increase in white blood cells, particularly macrophages, in the uterine lining. This is called leukocytic infiltration. These cells essentially attack and engulf sperm, and if it gets that far, the fertilized egg. It creates a hostile environment.
So that's the effect of the device itself. What extra effect does the copper or hormone add?
The copper ions released from copper IUCDs have direct effects. They interfere with enzymes and metabolic processes within the uterine lining that are essential for implantation. It makes the endometrium toxic to the blastocyst.
And the progestogen in Mirena.
Mirena adds powerful extra mechanisms. The levonorgestrel causes the cervical mucus to become very thick and dense, forming a plug that physically blocks sperm from even entering the uterus in the first place. It also causes the uterine lining, endometrium, to become very thin, atrophic, making implantation impossible. And as a bonus, it partially suppresses ovulation in about 10% of cycles.
Given how effective they are, what are the potential complications or downsides?
There are immediate or early issues that can occur during or soon after insertion, like pain, cramping, sometimes difficulty inserting it, or even, rarely, perforation of the uterine wall, about 1–2%. Expulsion, where the device comes out on its own, happens in about 2–5% of users, usually in the first few months. Spotting and changes in bleeding patterns are also common initially.
What about later complications?
Menstrual problems can persist for some women using copper IUCDs, heavier periods, menorrhagia, or more painful periods, dysmenorrhea. This is less common, often improved with Mirena. A significant concern is pelvic inflammatory disease, PID.
And the IUCD doesn't protect against the infections that cause PID, right?
Correct. Unlike condoms, IUCDs offer zero protection against STDs. The risk of PID is highest in the first few weeks after insertion, potentially related to contamination during the procedure, and overall occurs in about 2–5% of users over time. This risk is why IUCDs are often used cautiously or avoided in women at higher risk for STDs, like those with multiple partners or young nulliparous women. PID can lead to tubal damage and infertility.
And pregnancy with an IUCD, though rare, it happens.
Yes, the failure rate is low, maybe 1 to 3 pregnancies per 100 woman years for copper IUCDs, even lower for Mirena. But if pregnancy does occur with an IUCD in place, there's a significantly increased risk that it will be an ectopic pregnancy, one occurring outside the uterus, usually in the fallopian tube.
Why is the ectopic risk higher?
Because the IUCD is so effective at preventing pregnancy inside the uterus, if a failure happens, it's more likely implantation occurred somewhere else, like the tube, where the IUCD has less effect. The rate is about 1 ectopic for every 30 pregnancies that occur with an IUCD. The risk seems highest with the older progestogen device.
What happens if the threads aren't visible during a checkup? Where could the IUCD be?
Several possibilities. The woman could be pregnant, which can push the uterus up. The threads might have simply curled up into the cervix or uterus. The device could have perforated the uterine wall and be floating in the abdomen, or it might have been expelled without her noticing.
How do you figure it out?
First step is usually ruling out pregnancy. Then try gently probing the cervical canal for threads. If not found, an ultrasound is the best way to locate it within the uterus. If ultrasound doesn't see it, an X-ray can confirm if it's somewhere else in the pelvis or abdomen, since it's radiopaque.
And getting it out if it's misplaced.
If it's inside the uterus, but the threads are lost, usually a special hook, like Shurtkar's hook or hysteroscopy, a camera into the uterus, can retrieve it. If it has perforated the uterus and is in the abdominal cavity, it generally needs to be removed surgically, often via laparotomy rather than laparoscopy, especially if it's a copper device.
Why laparotomy for perforated copper devices?
Because the copper ions can cause inflammation and significant adhesions, basically scar tissue sticking the device to the bowel or omentum, the fatty apron in the abdomen. Trying to pull it free laparoscopically can be risky.
What if pregnancy occurs and the IUCD is still inside?
If the threads are visible, the recommendation is usually to remove the IUCD immediately, though this carries a risk of causing a miscarriage, which must be explained. If the threads aren't visible, removal is harder and riskier. Often, termination of the pregnancy is offered due to the increased risk of infection, preterm labor, and miscarriage if the IUCD is left in place. However, continuing the pregnancy with the IUCD is possible after careful counseling about the risks.
Beyond contraception, do IUCDs have other uses?
Yes, definitely. As we mentioned, the copper T IUCD is the most effective method of emergency contraception if inserted within 5 days of unprotected sex. It offers immediate EC and ongoing contraception. Inert devices were sometimes used historically to treat Asherman syndrome, uterine scarring, after removing the copper part. And Mirena is widely used therapeutically.
For what conditions specifically?
It's a first-line treatment for heavy menstrual bleeding, menorrhagia, and painful periods, dysmenorrhea. It's also used to protect the endometrium from hyperplasia, overgrowth, in women taking tamoxifen for breast cancer.
Okay, that's a very thorough look at IUCDs. Let's shift now to hormonal contraception, starting with the classic combined oral pill, the COC.
Right, the pill. It really was revolutionary. COCs combine a synthetic estrogen, usually phenylestradiol EE2, with a progestogen. We talk about different generations of pills.
What defines the generations?
It's mainly about the dose of estrogen and the type of progestogen used. First-generation pills had quite high doses of both hormones. We then moved to lower estrogen doses, now typically 20 or 30 micrograms of EE2, and different progestogens like levonorgestrel, norgestimate, desogestrel, gestine, and more recently drospirenone, which is found in pills like Yasmin, considered fourth generation.
How are they typically taken?
The most common regimen is 21 days of active hormone pills, followed by a 7-day break, or placebo pills, during which the woman has a withdrawal bleed, mimicking a period. Then she starts the next pack. Some newer regimens have shorter breaks or continuous dosing.
And compliance is absolutely vital.
Absolutely critical. The pill needs to be taken at roughly the same time every single day. The rule of thumb is if you miss more than one active pill or start the next pack late, you're likely not protected and need to use a backup method like condoms for at least the next 7 days while continuing the pills.
How effective is the pill when used perfectly versus typically?
There's a big difference. With perfect use, taking it exactly as directed, the failure rate is very low, maybe 0.3 per 100 woman years. But with typical use, accounting for missed pills, starting packs late, etc., the failure rate jumps up to around 5 to 8 per 100 woman years. Still very effective compared to many methods, but compliance matters hugely.
Now, the pill isn't just for contraception. It has some significant non-contraceptive health benefits, right?
Yes, and these are really important. COCs make periods very regular and predictable. They usually reduce the amount of bleeding, which helps prevent iron deficiency anemia. They decrease menstrual pain for many women. They also reduce the formation of benign functional ovarian cysts.
And critically, they reduce the risk of certain cancers.
This is a major benefit. Long-term studies show a significant reduction of the risk of both ovarian cancer and endometrial uterine cancer. And this protective effect seems to last for quite some time, maybe up to 10 years or more, even after stopping the pill. They also reduce the risk of pelvic inflammatory disease and ectopic pregnancy. There's even some evidence they protect against rheumatoid arthritis.
Okay, but there are risks too. Let's talk about the most serious one, blood clots or thromboembolism. How big is this risk with modern low-dose pills?
It's still the most serious potential side effect, and why careful screening is essential before prescribing. COCs do increase the risk of both venous clots, like DVT or PE, and arterial clots, like stroke or heart attack. The risk is highest in the first year of use and is estimated to be about 7 to 10 times higher than in non-users of the same age.
Why does estrogen increase clot risk?
Estrogen affects the liver, causing it to produce more of certain clotting factors, making the blood slightly more prone to clotting.
Did lowering the estrogen dose help?
Yes, significantly. Reducing the EE2 dose from the older 50 milligrams or even 100 milligram pills down to the current 20 or 30 milligram made a big difference in safety. However, the risk doesn't disappear completely.
And does the type of progestogen matter?
There's evidence suggesting it might. Some large studies found that pills containing the so-called third-generation progestogens, desogestrel and gastadine, might carry a slightly higher risk of venous thromboembolism compared to pills with older progestogens like levonorgestrel. This is still debated somewhat, but it's a factor clinicians consider.
What are the common, less serious side effects?
Things like spotting or breakthrough bleeding, especially in the first few months as the body adjusts. Nausea can happen, often due to the estrogen taking the pill at bedtime can help with that. Some women experience breast tenderness, mood changes, or headaches. And occasionally, some women might not get their period back right away after stopping the pill, post-pill amenorrhea, particularly if their cycles were irregular before starting.
Who absolutely should not take combined pills? What are the major contraindications?
These are strict. COCs are generally Category 4, unacceptable risk for women who have a history of blood clots, VTE or arterial, stroke, certain heart conditions like complicated valve disease or ischemic heart disease, uncontrolled high blood pressure, diabetes with vascular complications, known thrombogenic mutations, certain types of migraines, migraine with aura, active liver disease, or current breast cancer. Age over 35 combined with heavy smoking is also a major contraindication. Gross obesity increases the risk too.
Okay, so COCs are for everyone. What about progestogen-only methods, starting with the POPs or mini pills?
Right. Progestogen-only pills, POPs, contain just a low dose of progestogen, no estrogen. Examples include pills with northisterone or levonorgestrel, like LNG 30 milligrams. A key difference is they must be taken every single day, with no break. And timing is even more critical than with TOCs, often needing to be taken within a strict 3-hour window each day.
What are the advantages of POPs?
The main advantage is they avoid estrogen-related side effects and risks. This makes them a good option for women who can't take estrogen, such as those who are breastfeeding, women over 35 who smoke, or those with conditions like high blood pressure, certain migraines, or a history of VTE where COCs would be contraindicated.
How do they work differently from combined pills?
Their primary mechanism is thickening the cervical mucus, making it difficult for sperm to get through. This mucus effect is pretty reliable. However, they are less consistent at suppressing ovulation compared to COCs, maybe only stopping it in about 40% of cycles.
Is there an exception to that ovulation suppression rate?
Yes, there's a newer type of POP containing desogestrel, like Cerazette. This one seems much more effective at inhibiting ovulation, maybe 97–100% of the time, making its overall efficacy closer to that of COCs.
What are the drawbacks of POPs?
The main one is irregular bleeding patterns. Spotting, breakthrough bleeding, or even absent periods, amenorrhea, are quite common and often the reason women stop using them. And because ovulation isn't always suppressed, except with desogestrel, the overall failure rate with typical use is slightly higher than COCs, maybe around 2 to 3 per 100 woman years, largely due to the strict timing requirement.
Moving from daily pills to longer-acting progestogen methods, deco injections.
Yes. These are very popular globally. The main one is depot-medroxyprogesterone acetate, or DMPA, brand names like Depo-Provera or Antara in India. It's typically given as an injection every 3 months, 12–13 weeks. Another is northisterone and Netanthen, usually given every 2 months.
How effective are the injections?
Very effective. Failure rates are low, around 0.3 to 0.6 per 100 woman years. The big advantage is compliance. You get the shot and you're covered for 2 or 3 months. No daily pill to remember. They are coital independent and associated with a lower risk of PID and ectopic pregnancy.
What are the downsides that need careful counseling?
A major issue is menstrual disturbances. Irregular bleeding is common initially, but many women using DMPA long-term develop amenorrhea, no periods at all, maybe 20–50% after a year. While some women like this, others don't. Also, if side effects occur, like mood changes, weight gain, you have to tolerate them until the injection wears off.
And the return of fertility.
This is a critical counseling point.
Yeah.
Fertility doesn't return immediately after stopping injections. There's the delay. On average, it takes about 5–6 months longer to conceive after stopping DMPA compared to other methods. So it's not ideal if someone wants to get pregnant soon after stopping.
What about the bone density issue?
This is a significant concern, particularly with long-term DMPA use. Studies have shown it can lead to a decrease in bone mineral density, BMD, causing osteopenia or potentially increasing osteoporosis risk later. The effect seems partially reversible after stopping, but there's caution.
So, are there restrictions on its use because of this?
Yes. The WHO MEC guidelines reflect this. It's generally contraindicated, Category 4, for adolescents before they reach peak bone mass. For other women, long-term use, beyond 2 years, is often considered Category 3, meaning risks might outweigh benefits, and it should only be continued if other methods are unsuitable, with monitoring and discussion.
Next up in long-acting progestogens. Subdermal implants, like Implanon or Nexplanon.
Implants are small, flexible rods, about the size of a matchstick, inserted just under the skin of the upper arm. Implanon Nexplanon contains etinogestrel, a metabolite of desogestrel, and is effective for 3 years.
How do they work, and what are the advantages?
They release the progestogen slowly and steadily directly into the bloodstream, bypassing the liver-first pass effect you get with pills. Implanon primarily works by suppressing ovulation very effectively. They are extremely effective. Failure rates are very low, maybe 0.2 to 1.3 per 100 woman years, although efficacy might be slightly lower in women over 70 kilograms. Fertility returns quickly after removal, usually within 4 to 12
Big
weeks.
advantages.
Like other progestogen-only methods, the main drawback is unpredictable bleeding patterns, irregular bleeding, spotting, or sometimes amenorrhea. This is the most common reason for removal. Also, insertion and removal require a small procedure by a trained provider, though newer inserters for Nexplanon have made insertion simpler.
Okay, besides pills, injections, and implants, are there other ways to deliver hormonal contraception?
Yes, several innovative methods exist. There's the vaginal ring, like NuvaRing. It's a flexible ring the woman inserts into her vagina herself for 3 weeks, then removes for 1 week for a withdrawal bleed. It releases both estrogen and progestogen. Users often report less breakthrough bleeding compared to pills.
And the patch.
The contraceptive skin patch, like Orthoevra or Xulane, delivers combined hormones through the skin. You apply a new patch once a week for 3 weeks, then have a patch-free week. A potential issue is detachment, especially in heat or with friction, and efficacy might be reduced in women with higher body weight or obesity.
And let's not forget Centroman, the Indian nonsteroidal option.
Right, Centroman, also called ormeloxifene, brand name Saheli or Chaya, is unique. It's a non-steroidal pill developed in India. It's taken twice a week initially, then just once a week.
How does it work if it's not a hormone?
Its mechanism is different. It's a selective estrogen receptor modulator, SERM. It primarily works by altering the uterine lining, making it unreceptive to implantation. Crucially, it does not consistently prevent ovulation. This different mechanism might appeal to women concerned about hormonal side effects.
How effective is it?
The failure rate is reported as relatively low, around 1.83 per 100 woman years, with the recommended dosing schedule. It's also sometimes used as a postcoital emergency contraceptive.
That covers a huge range of hormonal options. Now, what about emergency contraception specifically? The morning after option.
EC is a vital backup, and it's crucial to understand it's not for regular use. It's for isolated incidents, unprotected sex, condom breakage, missed pills, sexual assault. It's always less effective than using a regular method consistently.
What were the early hormonal methods?
The first widely used hormonal method was the IUCD regimen. This involved taking multiple high-dose combined contraceptive pills within 72 hours of unprotected sex and repeating the dose 12 hours later. It worked, but the high estrogen dose often caused significant nausea and vomiting.
So what's used now?
The preferred hormonal method now is levonorgestrel, LNG pills, usually taken as a single 1.5 milligram dose like Plan B one-step, or sometimes as 2.75 milligram doses 12 hours apart, like Prostanar.
How does LNG work for EC, and what's the time window?
It's thought to work primarily by delaying or inhibiting ovulation. It might also affect the uterine lining or cervical mucus. It's most effective the sooner it's taken, ideally within 72 hours. But there's evidence of some effectiveness up to 120 hours, 5 days, though efficacy decreases over time. And because it's progestogen only, it's generally safe for women who can't take estrogen.
Are there even more effective hormonal EC pills?
Yes. Mifepristone, RU486, the progesterone receptor blocker, can be used in a low dose for EC. It works mainly by preventing implantation by affecting the uterine lining. It's highly effective, maybe only a 0.9% failure rate, and can be used up to 120 hours. Ulipristal acetate, ELA, is another option, a selective progesterone receptor modulator, Also effective up to 5 days and potentially more effective than LNG, especially later in the window.
But stepping back, what is the single most effective method for emergency contraception overall?
That'd be the copper T IUCD. If inserted within 5 days, 120 hours, of unprotected intercourse, it's extremely effective, with a failure rate of less than 0.1%. It works by creating that inflammatory reaction that prevents implantation.
It has that dual benefit.
Exactly. It provides highly effective emergency contraception immediately and then continues to provide excellent long-term contraception going forward. It's a really valuable option.
Looking ahead briefly, immunological contraception, a vaccine against pregnancy.
It's still very much in the research and development phase, but it's a fascinating concept. The idea is to vaccinate someone to create antibodies against key components needed for pregnancy.
What are researchers targeting?
Several targets are being explored. One is the beta subunit of HCG. The pregnancy hormone antibodies against it could potentially cause temporary infertility for maybe a year. Another target is proteins in the zona pellucida. The egg's outer layer antibodies could block sperm penetration or prevent the egg from shedding the zona properly after fertilization. There's also research into vaccines targeting FSH using inhibin to suppress follicle development. It's futuristic, but potentially revolutionary if safety and efficacy hurdles can be overcome.
Okay, now let's turn to the permanent methods. Surgical sterilization, for those who have decided they don't want any more children.
Right. Sterilization is intended to be permanent, though reversal is sometimes possible but complex. The ideal sterilization procedure from the sources would be simple, quick, done as an outpatient under local or short general anesthesia, leave minimal scarring, be 100% effective, which is rarely achievable, and importantly, be potentially reversible surgically.
Let's start with male sterilization, vasectomy. It's generally simpler and safer than female sterilization.
That's true. Vasectomy involves cutting or blocking the vas deferens, the tubes that carry sperm from the testes. It's usually done under local anesthesia, often using a no-scalpel technique which involves a small puncture instead of an incision, leading to less bleeding and faster recovery.
What is the absolute #1 counseling point after a vasectomy?
That sterility is not immediate. This is non-negotiable to communicate. There are still live sperm present in the reproductive tract downstream from where the block was made. It takes time and multiple ejaculations, usually estimated around 3 months or 20 ejaculations, to clear these remaining sperm.
So backup contraception is essential.
Absolutely essential until a follow-up semen analysis confirms azoospermia 0 sperm count. Only then can the man be considered sterile.
What are the common complications? Are they serious?
Complications are usually minor. Things like temporary scrotal pain, swelling, bruising, or a small hematoma blood collection happen in maybe 1–2%. Sometimes a small lump called a sperm granuloma can form at the cut end. Importantly, vasectomy does not affect testosterone production, sex drive, or the ability to have erections or ejaculate. The fluid is still produced, just without sperm.
Oh.
Any reports of decreased libido or impotence afterward are almost always psychological.
Is there anything new in vasectomy, maybe regarding reversibility?
Yes, the sources mention reversible inhibition of sperm under guidance. This is a technique developed in India. It involves injecting a non-toxic polymer gel directly into the vas deferens. The gel coats the lining and damages sperm as they pass through, effectively blocking fertility without cutting the tube.
And the reversible part?
That's the clever bit. The blockage can potentially be reversed by injecting a solvent, like sodium bicarbonate solution, to flush out the polymer gel. It offers the prospect of a reliable, long-acting, yet potentially non-surgically reversible male method, still under investigation for wider use.
Okay, now female sterilization, or tubectomy tubal ligation. When is this typically done?
It can be done at various times. Postpartum, often within the first week after vaginal delivery while the uterus is still enlarged and the tubes are easily accessible. It can be done during a cesarean section. Or it can be done as an interval procedure, meaning anytime unrelated to a recent pregnancy, usually at least 6 weeks postpartum.
What are the main surgical approaches?
The two main approaches for interval procedures are mini-laparotomy and laparoscopy. Mini-laparotomy involves a small incision, usually just above the pubic hairline or below the navel. It's technically simpler and requires less specialized equipment than laparoscopy.
How are the tubes blocked in a mini-laparotomy?
Several techniques exist, but the most popular and recommended is the Pomeroy technique. A loop of the fallopian tube is lifted, tied off with an absorbable suture, like catgut, and a section of the loop is then cut out. The tied ends eventually seal off as the suture absorbs. It has a low failure rate, around 0.4%, and importantly, because it damages a relatively small segment cleanly, It offers the best chance of successful surgical reversal later, if desired.
Are there techniques to avoid?
Yes, the Madlener technique, where a loop is crushed and tied with a non-absorbable suture, is generally not recommended anymore due to an unacceptably high failure rate, sometimes up to 7%, because the tube often finds a way to recanalize.
And laparoscopy, that's very common now.
Yes, laparoscopic sterilization is the most common method in many parts of the world. It involves inserting a thin telescope, laparoscope, through a small incision, usually in the navel, to visualize the tubes. Then instruments are inserted through the scope, or another small puncture to occlude the tubes.
How are the tubes blocked laparoscopically?
Usually by applying clips like Hulka clips or Filshie clips across the tube, or by placing a silicone band like a Philip ring tightly around a loop of the tube, causing it to scar shut. Electrocautery, burning, can also be used, typically bipolar cautery, which is safer than older monopolar methods as it limits the electrical current spread, reducing the risk of accidental burns to nearby organs like the bowel.
Do clips or rings offer better reversibility?
Generally, clips are considered slightly better for potential reversal. They crush and damage a smaller segment of the tube, maybe 3-4 millimeter, compared to the Fallope ring, which destroys a larger section, 2-3 centimeter.
What's the failure rate like with laparoscopy?
Overall, failure rates for laparoscopic methods are low, around 0.6 per 100 woman years. However, similar to IUCDs, if pregnancy does occur after tubal ligation, usually due to incomplete closure or recanalization, there's a higher chance it will be an ectopic pregnancy. The rate is maybe 2.2–2.3% among failures.
Are there serious complications with laparoscopy?
Risks include those related to any surgery and anesthesia, plus specific risks like bleeding, infection, injury to bowel or bladder, or uterine perforation during instrument insertion. The risk of bowel burns was higher with older monopolar cautery, but is less common with bipolar cautery or mechanical methods like clip rings.
There's also a method that doesn't require abdominal incisions, hysteroscopic sterilization, using the Assure device.
Correct. Assure was a method where small, flexible metal coils were inserted into the opening of each fallopian tube via a hysteroscope passed through the cervix. So no cutting involved. The coils were made of a nickel-titanium alloy inner coil and a stainless steel outer coil, with polyethylene terephthalate PET fibers woven in.
How did the coils block the tubes?
The key was the PET fibers. They were designed to irritate the tubal lining and trigger a benign, fibrous tissue ingrowth. Over time, this scar tissue would grow into and around the coils, permanently blocking the tubes.
What was the critical time factor here?
It took time for that tissue blockage to become complete, usually about 3 months. This was a crucial counseling point. Women needed to use another reliable backup contraceptive method during those entire 3 months. And then a confirmation test, usually a hysterosalpingogram, HSG, and X-ray with dye, was required to prove both tubes were fully blocked before they could rely on Assure alone.
And it was irreversible.
Yes, considered permanent and irreversible. Note, Assure is actually no longer available in many countries due to concerns about side effects and complications reported by some women, but the principle is relevant to hysteroscopic methods.
Even with intended permanence, regret is an issue with sterilization.
It is. Life circumstances change: divorce, remarriage, tragically the death of a child. Regret rates vary, but are significant enough that counseling about permanence is vital. This drives requests for tubal reversal surgery, tuboplasty, which can be successful in restoring fertility maybe 70–80% of the time, depending on the original sterilization method and remaining tube length.
Any other long-term issues after female sterilization?
Some women, maybe around 15%, report experiencing changes in their periods afterwards, sometimes called post-sterilization, abnormal uterine bleeding, AUB, although the direct causal link is debated.
Okay, that covers the methods. Now, how do we apply this knowledge to specific groups of people with different health needs or life stages?
This is where the WHO Medical Eligibility Criteria, the MEC, becomes incredibly useful. It's a standardized system to help clinicians decide if a particular contraceptive method is safe for someone with a specific medical condition.
How does it work, those 4 categories?
Right. It classifies the safety of using a method in the context of a condition into 4 categories. Category 1, no restrictions. The method can be used freely. Category 2, advantages generally outweigh theoretical or proven risks. Usually okay to use, maybe with some follow-up.
And the more restrictive ones?
Category 3, risks usually outweigh the advantages. Should only be used if safer, more appropriate methods aren't available or acceptable and requires careful counseling and monitoring. Category 4, unacceptable health risk. The method should absolutely not be used. It's a really practical tool for navigating complex choices.
Let's apply it. What about adolescents? What's generally best?
For adolescents, especially if sexually active, barrier methods, condoms, are strongly recommended, primarily for the vital STD/HIV protection. Combined oral pills, COCs, are generally considered safe, MEC category 1 or 2 usually, but some caution might be advised for very long-term use, say 4 years, starting in adolescence, especially if nullipris, due to some theoretical concerns raised in sources about long-term effects, though data is complex. Sterilization is legally and ethically inappropriate. EC and access to MTP, if needed, are crucial backups.
What about lactating women?
LAM is great for the first 6 months under the right conditions. After that, progestogen-only methods, POPs, implants, DMPA, and IUCDs, both copper and marina, are safe and considered category 1 or 2.
And combined methods, pills, patch, ring.
Combined hormonal contraceptives, COCs, patch, ring, are generally contraindicated, category 4 in the first 6 weeks postpartum due to increased VTE risk, and often category 3 or 2 between 6 weeks and 6 months if breastfeeding, because the estrogen can potentially reduce milk supply and small amounts pass into the milk. Progestogen-only methods are preferred during breastfeeding.
HIV-positive women, what are the key considerations?
Condoms are paramount, always, for dual protection preventing HIV transmission, to partner or from partner if discordant, and other STDs, and preventing pregnancy. A dual method approach is often best. Condoms plus a highly effective method like an implant, injection, POPs, or an IUCD.
Can HIV-positive women use IUCDs?
Yes, according to current WHO guidelines, women with HIV who are clinically well on antiretroviral therapy and don't have active pelvic infection can generally have an IUCD inserted, MEC category 1 or 2. Proper screening for other STDs is important.
What about women over 35? Choices become more complex.
They can, largely depending on their overall health profile. Factors like smoking, obesity, hypertension, diabetes really come into play. If a woman over 35 is healthy, doesn't smoke, and has normal blood pressure, a low-dose COC might still be an option, category 2, up to age 45 or even menopause for some. However, progestogen-only methods, or IUCDs, especially marina, which can also help with common perimenopausal bleeding issues, are often preferred choices.
And sterilization.
Sterilization becomes a more common consideration for women over 35 who have completed their families. The surgical risks need to be weighed against the remaining years of potential fertility and the risks-benefits of continuing other methods.
Let's explicitly compare marina versus tubectomy, as marina seems positioned as a modern alternative to surgery.
It's a very relevant comparison. Marina offers efficacy that's nearly identical to tubal ligation, extremely low failure rates. But its huge advantages are that it's completely reversible, involves no surgery or anesthesia risks, and often provides significant therapeutic benefits by reducing heavy bleeding and period pain, which are common issues for women in their late reproductive years or perimenopause. For many, marina offers a highly effective, long-term reversible solution that addresses multiple issues, making it a very compelling alternative to permanent sterilization.
That's a fantastic overview of how these methods apply in different contexts.
It really highlights that there's no single best method. It's always about matching the right method to the individual's health, lifestyle, and reproductive goals at that point in time.
So wrapping this deep dive up, we've covered an enormous amount of ground.
We really have. From, simple awareness methods with high failure rates driven by human factors, right through to these incredibly effective, long-acting, reversible methods like IUCDs and implants and permanent options. And technology keeps evolving. Lower dose pills, new delivery systems like rings and patches, non-hormonal options like centromin. The landscape is always changing.
And what stands out is the constant tension between efficacy, safety, side effects, and user convenience or compliance. Getting that balance right is key. We saw how a method nearly 100% effective, like the pill, still carries that small but serious risk of thromboembolism, needing careful screening, while something totally safe like the rhythm method might fail a quarter of the time.
It underscores that the absolute bedrock of safe and effective family planning isn't just the method itself, but the quality of the information and counseling that allows for truly informed choice.
Which leads us to our final provocative thought for you, the listener. We've seen how complex choosing the right method is, with all the dose-dependent risks like VTE, the numerous contraindications, the nuances for different populations captured in things like the WHO MEC wheel. Given this complexity, how could tools like that MEC wheel or similar frameworks become more accessible and understandable, not just for doctors, but for individuals themselves? Could empowering people directly with this kind of risk-benefit assessment tool fundamentally change how contraceptive choices are made, moving towards more shared decision-making?
Something to definitely think about. How do we best translate complex medical knowledge into truly empowering personal choices? Thank you for joining us on the deep dive.